put this in my... Okay. So first of all, thank you very much for this kind invitation. It's always a pleasure to be here in Bilbao at this wonderful meeting. And my task here is to try to give you some evidences related to the use of micro-ultrasound, especially in comparison to what we can consider nowadays the gold standard in the diagnostic pathway of patients with a suspicion of prostate cancer. So I will start my talk talking about guidelines. So what are the current guidelines saying about multiparametric MRI? Well, they will change soon probably, but right now the EAU guidelines recommend the use of multiparametric MRI and of a targeted biopsy just in the repeat biopsy setting, saying also that a systematic biopsy is always needed, and pretty much the same with the NCCN guidelines that do not recommend the use of advanced biopsy technique initial biopsy setting. Taking in mind these, we also have to keep in mind that MRI is not a perfect tool. First of all, high quality MRI is critical to the success of a targeted biopsy. There must be some teamwork between urologists and radiologists, and there are some cases of MRI invisible prostate cancer, at least 10%. It is also important, this sentence here, so we, as if we decide that the biopsy is indicated on clinical grounds, a negative MRI should not preclude it. There are some patients, we all know, that have some contraindication to MRI, where an MRI could not be accessible, for example, in some areas or some factors. So it's not that easy exam everywhere. And we know that there are many evidences around the Precision trial, the Promise trial, but I want to point out the results of this recent study published on the Lancet Oncology by the French group. I think it's very interesting because in this population, all patients received both the trust-guided systematic biopsy and MRI targeted biopsies. So every patient was the control of himself. And according to this study, actually the combined approach, combining both the systematic biopsy and the targeted biopsy, should be performed because it's the one that warrants the best diagnostic accuracy. Another important thing I think to point out is that if you look at the results, almost 50% of patients that were diagnosed with prostate cancer in this population has a suspicious. That means that probably their tumor arises from the peripheral part, MA visible by some other technique that I'm going to tell you about. So an ideal alternative to this approach, the MRI targeted approach, should be indeed accurate, should be easy to learn and easy to use, so should warrant a precise and real-time targeting, and be cost-effective, should be cheap as well. And there comes this new technology from my perspective. So what is micro-ultrasound? I think all of you already know it's a ultrasound machine that works at very high frequencies, therefore providing us highly detailed images of the prostate. And actually these images were used to develop a risk score, as was done for the parats in a multiparametric MRI, that goes from 1 to 5, where 1 and 2 is negative. There is a pattern 3 that is the gray area, and the 2 patterns, the 4 and 5, are normally related to significant prostate cancer. And these are the results of the first validation study that was published 3 years ago in the Journal of Urology, where actually the results show a linear relationship between a Primus score and the presence of clinically significant prostate cancer. And these results were actually validated also recently by an American study presented at AUA 2018, where actually the purpose of the to interpret this primus score increase after 15 cases, so it appears that there is not such a learning curve, and more importantly, the performance is better when it is aggressive, is clinically significant. We start to have some evidences related to micro-ultrasound, and I'm going to show you some of the studies that we have that compare the two diagnostic tools. So first of all, a study where we try to compare the target that were found either at a micro-ultrasound or at MRI in a population of more than 100 patients that were biopsied with all of these patients had a positive multiparametric MRI and were biopsied both on the target of the multiparametric MRI and eventually on the target given by the micro-ultrasound. And here you can see this figure that shows the performance of multiparametric MRI on top, the performance of micro-ultrasound in the middle, and a comparison of the concordance between multiparametric MRI and micro-ultrasound detected lesion. And the yellow, the better, the green is still a good performance, while the blue is not performing that good. So we can see that, not surprisingly, the multiparametric MRI appears to perform very well in the anterior and transition zone of the prostate, and fairly well also in the apical part and the lateral part of the prostate, while micro-ultrasound, not surprisingly, appears to perform very well in the peripheral part of the prostate, both in the base and the apex. Not so bad, actually, in the anterior and transition zone. That was kind of surprising to me, while was lacking a little bit of accuracy in the lateral portion of the prostate, and I can explain this because you just get longitudinal scans of the prostate. You may lose some tumor very far in the lateral horn of the prostates. And these are just a couple of examples. So this figure was a Parat's 3 lesion that actually there was a concordance with a Primus 4 smudge lesion, and the biopsy confirmed the presence of a 3+4 cancer here. And this other image was a Parat's 5 lesion at the left apex of the prostate that was actually also confirmed as a mixed echo lesion that was given a Primus 5 and was biopsied and was a Gleason 4+3 disease. And when we look at this table, I think it's nice to see that the performance is not that different, but it's also nice to see that these two diagnostic tools may provide some independent information. For example, both of these tools works very well in the apex, but if we look at the lesion concordance, we can see that there are 60% of the lesions that were concordant. It means that there were 40% of the lesions that were independently found by the two methods. Another study was this multi-institutional effort that we ran together with the Bilbao team and the French team and the United States. Was an initial experience putting together all the experiences from this team worldwide, and what we look at was the sensitivity of micro-ultrasound as compared to that of metric MRI, and from this forest plot we can actually see that at least the micro-ultrasound appears to be non-inferior to MRI in terms of sensitivity, or its diagnostic performance appears to be comparable to that of multiparametric MRI. Again, a couple of examples here. So this was Parat's 4 lesion. It was confirmed as a Primus 5 a mixed echo lesion at the apex and was biopsy and was a Gleason 9 disease. And this other case that was again a Parat's 4 lesion that was actually involving pretty much all the periphery of the prostate was also confirmed as a Primus, and biopsy was a Gleason 7 cancer. And this was the diagnostic performance of the micro-ultrasound as compared to multiparametric MRI, and actually the sensitivity and negative predictive value were good, not that good, the positive predictive value and the specificity, and we'll talk about this later on. Another study is this one that we recently actually published on European Urology Oncology, again comparing this population of 104 patients that had multiparametric MRI targets and were also subjected to micro-ultrasound. And going to the results, we have actually 34% of these patients having a clinically significant prostate cancer at biopsy. And at the very end, just 2 of these patients were missed at micro-ultrasound, and both of these tumors were actually located in the transition zone of the prostate, which makes sense to me. This is a nice example. I think that this was a patient that was under active surveillance. Here you can see these previous needle tracks that were related probably to the previous biopsy of this guy, and here we have this hypoechoic primus 5 lesion with also an irregular prostate border, I would say here. And we target biopsy of this lesion here, and actually was a +3 disease that was also confirmed at final pathology because this gentleman had a radical prostatectomy. And population, the fact that we have ultrasound that was negative provide a 72% reduction in the probability of having clinically significant prostate cancer. So we may conclude that the great majority of these patients may not harbor clinically significant prostate cancer, at least in the peripheral part of the prostate gland. To conclude, I think that micro-ultrasound appears to provide a good diagnostic performance in terms of sensitivity, negative, and it appears also that may be used as a complementary approach because both multiparametric MRI and micro-ultrasound may provide information in terms of presence and the location of prostate. Therefore, it may be an easy-to-use approach that could be used also in the diagnostic setting and also eventually to follow patients, for example, under active surveillance. It is not indeed a perfect diagnostic tool, so there are of evidences that we have to put together. First of all, it's a subjective examination. This is true also for multiparametric MRI, but it's even obviously more true for a ultrasound-based imaging tool. It has a learning curve indeed. There may be some problems in evaluating very large prostates. Prostate gland more than 100 grams may be not that easy to be evaluated, and to evaluate also the transitional zone correctly. And it still has a low specificity and positive predictive value, so we are still probably taking too many unnecessary prostate biopsies. Thank you.